I want to thank everybody for coming on board to our webinar today on the proper billing and reimbursement for telemedicine. We're going to do a little bit of house cleaning. We've set everybody up so everybody's muted that's attending. This way we can go through the presentation, the conversation, but we want this to be about you, not about us. So we set a 10-minute Q&A at the end. This way we can answer any questions you may have. So if you can, in your chat window, please put in any questions you may have, and we're trying to address as many as possible at the end. We definitely want to hear from you. Instead of it being about us, we want to hear from you and some of the challenges you may have. We should be able to give some answers that might be able to help you in what you're trying to get accomplished. So with that being said, I wanted to go through a little bit. Give me 1 second, hold on. Let me do one bit of house cleaning. Okay, want to at least touch bases and talk to everybody why we're doing this. Okay, what we found is we're putting together a group of webinars to help equip healthcare providers with information on how to make better decisions for their practice. Most practices we've been in contact with just don't have the right information of how they should be doing operations. And with what's going on, this is becoming fatal. And they're seeing it more and more of how important it is to have the right information at the right time to do things and make proper decisions for their practice. You know, healthcare providers need to make a smart and better decisions on how to do business and understanding the tools as well as the resources they need to do it. One of the biggest problems we see on our side is the healthcare provider not having professional advice, especially around their technology and how it affects their operations. And the current events have shown the effects of not having a comprehensive plan of how to address these things. So we've decided to put together a resource of partners, like a knowledge pool of people that have components like components for the medical practice, like technology, medical records, communications, insurance, legal, accounting, and medical billing. Pooling that information so they have a good resource to get answers for these questions, because it's not just one component of practice, it's everything across the board. How does all this stuff work together? And most practices only have bits and pieces. We're trying to put together resources that have all the answers in one place across the whole practice. With that being said, let me introduce myself. I'm Wayne Roye. I'm the CEO of Troinet. Our company is Troinet. It's a technology firm, and we focus on adapting technology into the operation of a healthcare provider. We and our partners are looking to help you make better decisions in your practice and how you do business. And today, that's why we have one of our partners, Rohit Maharishi. He's the founder of Advantrix Corporation. Advantrix offers medical billing, denial management, and business analytical services. And what makes Advantrix unique and why we've partnered with them is they've figured out a way to look at the business challenge of medical billing, and through their vast knowledge of understanding rules, regulations, and processes, finding ways to make it simpler and fast for the medical practice to get paid on these claims and what they're putting in. So a good way of looking at this, Troinet helps adoption and use of technology within the practice. Advantrix helps you get paid with the use of the tools within the practice. So with that being said, I want to bring Rohit on. I want to do a bunch of the time. I want to bring him on board. And Rohit, if you can now go into, you take the medical practice down this journey of what they should be looking at now with telemedicine and the billing of it.
Thank you, Wayne. Hello, everyone. I'm Rohit Maharishi, founder CEO of Advantrix Corp. We are a RCM billing service serving providers across 8 specialties. And we welcome you here today in this Troinet Advantrix TeleHealth billing session. So billing, even during the best of times, is confusing. Anyone who has ventured into this will vouch for it. So the rush for telehealth during this pandemic has been truly unprecedented, and someone like us with close to 20 years and millions of claims worth of experience, even we had to scramble. I will admit this. So we had to reach out. We feel a lot of queries from our clients. We had to reach out to a lot of contacts that we have with the payers, with CMS, and information was all over the map. and the rush was truly unprecedented. So we decided that we will try to declutter and try to simplify if we can, and if we can, make our small contribution in just trying to simplify, this as much as possible, and ensure that providers who are, in any case, scrambling now to adopt telehealth and service their patients, give them the care which is so much needed in these very tough times. At least, they get reimbursed for what they are doing. So we'll try to declutter and, take you, down this path where we will discuss few points or few, terminologies that you have been hearing, and its information is conflicting, many times. So telehealth, telemedicine, interchangeable terms, but we prefer to use telehealth. It's a broader term. So let's start with telehealth versus video conferencing. Something which is the most basic thing is that how to do telehealth. Is a phone call? Is it a e-visit? It has to be video. If it's a video, what video? Patients cannot connect through video, or they're not tech savvy. So many things are there. So let's try to declutter this and see what it is. So telehealth versus video conferencing. Is video conferencing HIPAA compliant? Well, it's not that complex a question, but it can bring on several types of answers. So simple answer is that video conferencing can be compliant with the government's mandate for health security standards. However, not all major video conferencing solutions can meet the HIPAA standards, and especially the big industry names like Skype and FaceTime. Now, during this time, not meeting HIPAA standards does not disqualify someone. So Skype and FaceTime, are allowed. In order for a health organization to ensure that they're in good accordance with the HIPAA regulations, they will need to err on the safe side. So it's recommended that any provider using a video conferencing solution must have a solution that offers complete encryption of any personal patient data. As telemedicine continues to grow and become a norm in today's society, more and more video conferencing solutions are increasing their security standards to meet the standards of HIPAA and other security protocols. So as I mentioned here, that Skype, FaceTime may not meet HIPAA standards, but they are allowed. So as a provider, it's not just about right now. It's not just about COVID. We will get over this. We will get out of this sooner or later. It's important that what you do now is going to stay with you. So maybe you should adopt a more thoughtful strategy as to what you want to do. And as a provider, if you're being told that HIPAA standards are being relaxed, they are, but not forever. So once this is over, things may come back, so it's important to err on the side of safety. Now, HIPAA policy changes during COVID-19. So we'll just try to summarize few points which can make a little bit sense out of this whole thing. That what are the main pointers here, that what HIPAA policy changes have taken place. So as we have all seen that during this pandemic, telehealth usage has dramatically increased across the spectrum, whether it's providers, whether it's a type of providers or patients. So while HIPAA rules have been relaxed, violations may still be levied. It's very important that we remain compliant as much as possible. So as I had mentioned in the earlier slide, that some standards have been relaxed, but we must try to remain compliant where we can and as much as we can. The providers must use an interactive, real-time audio and video telecommunication system in order to bill office visit codes like 99201. If the patient does not have access to a smartphone or computer, do not bill office visit codes. CMS specified that Facebook Live, Twitch, TikTok, or other public-facing video tools should not be used for telehealth. So once again, an important distinction. TikTok, Twitch, Facebook Live is not to be used. It is not same as using FaceTime or Skype. HIPAA privacy rules waived may use FaceTime, Skype, Messenger video chat, Google Hangout. CMS instruct groups to notify the patient that third-party platforms may have privacy risks. Now, you're using FaceTime or Skype. We all understand that the encryption standards do not meet HIPAA guidelines. So, you can use it, but just once again, erring on the side of safety, taking the right precaution, you should notify the patient when you get on the phone or video chat with the patient. First time patient is using telehealth with you, make a small disclaimer so that the patient is aware. If you have a website, you have a webmaster, a small one paragraph disclaimer there will be very helpful, something you can post on your front desk. So it's just keeping you safe and letting the patients know, that what you're using, you cannot guarantee if that platform is fully encrypted or not. The provider may waive the copay deductibles, but it's not required to do so. So right now the rule is that if it's a COVID-19 patient, no copays. Or in some cases, if insurance benefits are providing telehealth and many of those benefits are coming without copay, that means patient doesn't have to pay copay, you will not charge copay. But otherwise, you can charge the copay. And most commercial policies right now have no defined benefits for that. So yes, you can go ahead and you can charge the copay. Visits are paid at the same rate as in-person visits, so very important to know that. You do not need to record visits on any platform. Very important point. Many video conferences, especially in the corporate setting, those meetings are recorded. So it's easy to record these, but should you record these? The answer is no. We discourage because video recordings can be easily compromised and will provide a wealth of information about the patient. Anybody who's not authorized will access that. So for your protection, for the patient's protection, we highly recommend do not record those calls. But you do need to document the visit in the EMR. So it's a difference here. Do not record using the video audio tools, but please do document it. You need to write a proper note using the telehealth template, including a history, limited physical exam, and an assessment plan. Please check with your EMR vendor if they're providing you with a telehealth template. It's a good guided path, so will be helpful, and also those templates help you document faster so that you spend less time on documentation and more time actually interacting with the patient. Now, what are those tools and tips for documentation? So we'll just cover a few. So accurate documentation is just as important for telehealth visit. In my opinion, maybe even more important now because you're missing the physical proximity with the patient. So yes, your documentation can cover some distance there. Pre-COVID, only established patients were allowed for telehealth. During COVID, new patients are also allowed. Now, it remains to be seen that post-COVID, whether this provision will remain in place or not. So far, it is there. So yes, feel free to even have new patients on telehealth. Accepted codes are only the E&M codes, evaluation and management. However, during COVID-19, well visits are also included. So good practice is to inform the patient prior to the call what are the requirements. So if you are doing a well visit, patient must report to you vitals. So please do let them know temperature, like blood pressure, height, so that you can do a more meaningful well visit. And then any other vaccinations and all that, those obviously you have to schedule a visit in the office. You must document time in your note by clicking the time button in your EMR or using the time quick test. Protocols will remain same as a face-to-face visit. Must have at least 2 out of 3 history, physical, medical decision making to determine the E&M coding level. So it's a very subtle point, but important. Providers many times will say that we are using 99213, 99214. So that's the indicator. That's true. But when and if the documentation is challenged by the payer, you build for for MDM, which was showing at a moderate level, but they come back and they say no, it is at a low level. So your documentation is being challenged. In that event, if your notes had time noted there that how much time you actually spent, you will have an upper hand. So no harm. In fact, it's a good practice to do that. Good practice to document the originating, which is your site, and distant, which is patient site. So very important aspect of the documentation here. Now, telephone evaluation and management services. So what is a telephone call? Is it same as a video conferencing call? A lot of confusion about it. Let's see if we can try to make some sense out of this. So CMS has finalized payment for telephone evaluation and management, CPTs 99441 through 99443. These codes now are considered active and payable for duration of the COVID-19 pandemic. CMS will also allow physicians to provide telephone EM services to new and established patients both. So telephone EM services are provided to a patient, parent, or a guardian and do not originate from a related EM service within the previous 7 days and do not lead to an EM service or procedure within the next 24 hours or soonest available appointment. This is an important aspect to know here. Following codes may be used by physicians or other qualified health professionals who may report EM services. So 99441, 442, 443, all time-based, you can see here. Physicians can reduce or waive cost sharing for these services. We discussed that earlier. Reimbursement is lower than the audio-video encounter. So this is the gist of the answer here, that it is not same, it is lower than the audio-video encounter. Commercials will require patient benefits verification. So commercial insurance, please do check the benefits verification there. There are a lot of services that are covered, will be paid, but those benefits must be specifically checked. May not be available on a standard web check. So you may have to place a call, but we believe that the time invested in that is worth, because you may learn, and if you ask, they will tell you, and you may realize that certain services that you thought were not covered are actually covered and will be paid. So no harm in doing that. In fact, it's a gain to do that. Medicare also accepts G2012 for virtual check-ins, and this has been in place prior to COVID. It's only applicable for 5 to 10 minutes interaction and can be conducted through multiple communication technology modalities, including synchronous telephone conversation or exchange of information through video or image. Call must only be initiated by the patient. So prior to COVID, many EMRs were offering, or they offer actually, patient portals, and sometimes patients would interact with the physician through those portals. So this is what it relates to. Just an aside, but an important distinction. So we thought we should include it here. Corresponding e-visit codes are separate, and corresponding NPPA codes are separate. So if you have NPPAs in your practice, it's important to know that those corresponding codes are going to be different codes. So place of service. Place of service can often result and does result in claims denial. And especially when the rush was there, we experienced hundreds of claims getting denied, not because we had done any error, but because we had done the right code, and we still got denied. So the place of service code from CMS in 2017 was 02 for telemedicine services. On March 30th, they came out and stated that it's no more required to use 02, but should use the place of service that would have been used if the patient was seen face-to-face. This means office visit services will be paid at the higher non-facility rate, not the lower facility rate. So, 11, your office visit code, that is what you can use. TeleHealth for specialties. So clinicians who may not independently bill Medicare for E&M services like physical therapist, occupational therapist, speech, language, pathologist, clinical psychologist, they can use the following codes. So G2061 through G2063, you can see them that over 7 days and time bound 5 minutes to 10 minutes and going all the way to 21 minutes, but over. Now, one important distinction here is that commercials, they have more extensive code coverage, including IE, including RE, that is initial evaluation, repeat evaluation, therapeutic activities, etc. However, patient benefits must be checked. So I cannot emphasize enough on checking the patient benefits, very, very vital aspect. When you are calling in, once again, the benefits may not be visible on a standard web search. So a call might be required that when you call them in, you have to be specific and ask that this is covered, or this is not covered, so that you know. And once again, we reiterate that commercials are giving quite an extensive coverage for people like physical therapists. So it's vital that this is checked so that the patients can be serviced better, and the telehealth benefits, the benefits can be extended to both the providers as well as to the patients. Now, follow-up visits. Any limitations on follow-up visits in terms of number of days between the two sessions? Well, currently there is no limitation in number of days between the two sessions of telemedicine encounters. However, there are limitations for e-visits where the patients must generate the initial inquiry and asynchronous communications can occur over a 7-day period. So we did speak about e-visit earlier, which is separate. So for a standard telehealth right now, there are no limitations. Is it going to remain this post-COVID? Right now, it's difficult to say that. There might be some limitations imposed, but right now, there are none. In the end, we'll try to summarize some of the benefits which everyone now knows, patients, providers, telehealth is all over now. It's just trying to summarize it and put things in perspective here. So obviously increases access to healthcare. Remote patients do not have to travel for treatment. Instead, the doctor will come to them. Rural metropolitan hospitals now can have video consults with specialty providers. Chronically ill patients can have daily monitoring in the comfort of their homes. Improve healthcare outcomes, increase the monitoring of chronic conditions. Reduce no-shows, very, very important. Every provider faces no-shows, and many providers struggle that should they be charging the patients for no-shows? Is it even legal to charge patients for no-show? In many states, it is actually not even legal to do that. But it's a struggle that we have seen across the board, big practices, small practices, different specialties, every day of the week. Patients, for some reason, some patients will be no-shows. So this telehealth hopefully will do that it can reduce the no-shows. They will be less likely to skip the follow-up, if they are having to connect to you from the comfort of their home. So improve mortality, reduce complications, cut hospital stays, readmissions, lower healthcare cost. If telehealth, the way this is now moving forward, and in many cases, it can help you scale back or scale down your physical infrastructure. Not to say that you will not need an office. Yes, you will need an office, but definitely telehealth can help you lower the healthcare cost also. Reduce readmissions, ER visits, patient transfers, reduce medical practice overhead. So I hope that you found this information useful, and I sincerely hope that as we attempted to do, we were able to declutter some of some of the confusion that has been swirling around this whole issue of telehealth. So we'll be happy to take any questions you have now. Wayne, over to you.
Well, thank you, Rohit. But what I got from this is telehealth is not going away. It's something that's going to be evolving and changing the way medical practice is going to do business. So we really have to sit
Wayne,
down and be.
yes, you're right, and very interesting statistics that we have seen is that they're saying that by 2030, 60% population will be like a senior citizen population. So, and telehealth, as might appear that it is focused on on younger generation, but actually it is focused on older generations, on senior citizens, because they are the ones who can benefit the most from this.
That is correct.
So yes.
So bottom line is you have to be creative of how you use telemedicine. It's not, it definitely doesn't replace having somebody come into the practice, but it allows you the ability to narrow down your differentials for senior patients. One of the benefits of a lot of practices don't pay attention to when it comes to telemedicine is they now have the ability to actually come inside the home of the patient and see some of the economic situations happening in the home, to see some of the things that may be causing the symptoms to be able to diagnose. But we have to be strategic and smart on how we using telemedicine, placing it for where it fits. And right now, since the struggle getting patients in, how can you be smarter about how you see patients and how can you leverage telemedicine, because you can't have them coming through the door right now. So with that being said, because we're running into our Q&A, let's jump directly into Q&A right now. And let me pull up something from the board real quick. Here, I have a quick one that's really short, so let me jump on this one first. The question is, can you charge more for after-hour billing?
Yes, you can. So there are no specific guidelines on this right now that you cannot. So like AMA has actually sent a notification urging members not to do that right now during the pandemic. So many providers are not doing it. It's a kind of a service. So having said that, we say that if there are after hours, weekends, you can apply the modifier, send the bill in, and see some payers are paying, some may not pay. But yes, no harm in doing that.
Excellent. Here's one I throw at you. If a patient has a telephone evaluation 99441 on Monday, which results in a lab work needing to be done, can we charge on Wednesday a 99212 face-to-face call when we go over lab results?
When you go over the lab results, you are doing this on a Wednesday. The telephone call was on a Monday, so they have, and it's related to the same event. So yes, you should not be charging for that face-to-face. No. If something else is there other than that, then yes. If you're calling in the patient for something else now, you need to do something beyond this now, then yes. But just to discuss that, you should not.
Great. Okay, I have another question. I'm going to reword this in my own words. This is a physical therapist that's struggling with how do they bill, how do they utilize telemedicine physical therapists? And I actually throw one in because I know I've dealt with this with chiropractors, because those are a struggle too. Do you have any feedback of how they can actually level telemedicine, and can they get paid?
So yes, we had when it comes to Medicare specifically, Medicare has already given their G codes, and so they have already specified that what can happen over 7 days. But when it comes to the commercial, um, there are more extensive benefits, there are more extensive coverage for physical therapists. So when they do the benefits verification, that is where they should specifically check that what benefits are covered. Now, how to do that? Uh, you should be code specific when you are doing the benefits verification. You should specifically ask that is this code going to be covered? Is this going to be covered? So in commercial, there is a coverage, and of course it will depend, what kind of a plan patient has. So within the same insurance, there are so many different flavors now of plans. So it's not going to be specific that this is A insurance, so this will cover, or B insurance will not cover. No, it's a plan specific. So the key here is that benefits verification, an extensive benefits verification, that is the key. So, somebody like a physical therapist, they can give the benefit of telehealth to their patients. They can monetize it, provided they're doing their benefits verification the right way. So, I cannot emphasize enough how important it is to check the benefits.
So how does that also affect like voluntary surgery?
I'm sorry?
What about voluntary surgery? How's that being affected?
Oh, well, the surgeries, obviously, they have been asked, to put them on hold. So something which, which, if it can be rescheduled, postponed, without endangering the life, then yes, it is to be put on hold. So in many cases, surgeries would require some kind of a pre-authorization, certification, pre-certification. So the providers are patients are being advised that if it is not a life-threatening situation right now, yes, it can be put on hold, should be put on hold. Any consults related to that, once again, then it will come back to the same principles of telehealth, that if it's not a surgery, you are just doing a consult, then can you do that over telehealth? Yes, you can do that over telehealth.
Gotcha. Okay, I have another question for you. Can you use the in-office POS code for telehealth for commercial insurance too, or only Medicare?
Can you use, point of service code?
Code for telehealth for commercial insurance too, or is that only exclusive to Medicare?
No, for commercials too. That's what we mentioned. Medicare is specifically stated 02, as a place of service code, but you can use that now for everyone. Like your office visit code, like 11, you can use that, yes, for everyone.
Okay, good. So we're running out of time. I have a slew of more questions. What we're going to do is, if you guys can please shoot us with an email. My contact's up to any questions you have. We'll definitely get back to you and give you answers to the questions. I'd like to throw one more question at you before we get off the line. What's the top suggestions or things you think that these medical providers should be doing now to help them just see more patients and being able to survive this time period we have where people are not coming into the practice? What are some things they can utilize and top things you suggest?
So what we noticed, that at least during the initial weeks, there was hesitation, and we deal with providers, so we were told that, oh, our patients are not tech savvy, or they will not be able to connect on video calls. And there was a preference only to do a telephone call. So we try to encourage our providers that how they should adopt how they should adapt to telehealth now. So few housekeeping items here are that there are quite a good many platforms now. You check with your EMR vendor. They probably have a service already which can be plugged into your existing EMR, or can be even plugged into your website. Or you can use third-party tools like Doxy.me, which even have free accounts. So you don't have to do FaceTime or Google Hangout or Skype. You can use one of these tools. They have been very intuitively designed. But when you do that, it's important that you should be able to advertise, publicize to your patients that A, you have presence now on telehealth. B, linking with you or connecting with you on telehealth is just a one-step process. So important to make sure that whatever platform that you use, it should be a one-click method. It should not be a very complex method to connect with you. Three is the protocol, that how a patient now, obviously you do not want to have a walk-in kind of a situation here. So many providers were taking walk-ins. They do take walk-ins. So you should have, a patient should know that are they calling your office number? Is someone available in the office to take the call? Or many phone systems allow you to forward the call. So if your staff is not available physically in the office to attend to patient calls and book an appointment, maybe you should direct those calls to some number somewhere where people are available during office hours. So the patients are calling, those calls are attended, patients are given appointments for telehealth visit also. Then you should try to use some kind of a email blast or text blast, SMS blasting, to send your link to patients. All your active patients should know whether they are going to call you for telehealth or not. Does not matter. You have 2,000 patients, active patients. Please let them know that you are on telehealth and this is the link to connect to you via telehealth. What number they should call, the timings. So these are important housekeeping points that one should do. Also, as provider, someone told us that we are not a tech support service. That's true. You're not a tech support service. But look, if you can help your patients, try to connect to you or, navigate through this, at the end of the day, the patient, care is important. So by any means, these services are very intuitive. It does not take more than a couple of minutes to learn what settings, changes or fixes you need to do on your PC or your smartphone in order for you and the patient to be able to connect on a video call using the microphone and the camera of your phone or your computer. These are small, very minor tweaks which anyone can do. So it's all over the internet. Please have 4 or 5 steps documented so that you can share that with the patient if a patient is struggling. And many patients are shying away from connecting to you on telehealth only because of these limitations. So if you can do that, you are actually doing a great service to the patients and also helping to drive patient footfall to your practice now. So we highly recommend that you're not a tech support, but you can definitely extend this kind of help. You or your staff should be able to help the patients.
Rohit, you hit on a good point. You have to make it as easy as possible. And another point, I'm not sure if you mentioned it as well, is A, you want to be able to reach out to let them know you're available for doing a telemedicine session. B, you want to make it easier for the end patient to connect to you. And C, if you're not utilizing some form of credit card or ACH or automatic billing system that allows them to pay quickly via credit card, then you're doing them a disservice. You're limiting yourself in what you can do. So utilizing those 3 things and making it easy, because if you can accept a credit card, you can easily get paid for your patient visits as well, for any of the co-pays. So you definitely want to get those 3 things in place and make it as simple as possible for the end users. But Rohit, we're going to wrap up. Like I mentioned to everybody, please feel free to reach out to us. We're here for you. We want to help the medical community as much as possible. My email is here. shoot any questions that didn't get answered. I realize I don't have everybody's email, so if you can shoot me the questions, we'll definitely get back to you and let you know. I'll give you all the answers to your questions, as well as if you'd like a copy of this webinar, so shoot us an email as well, and we'll send you the link to the recorded session for the webinar. I'd like to thank everybody. Rohit, thank you very much, and have a good day.
Thank you. Thank you.
Bye.
Bye.